Hi there everyone, welcome to this RadCast Academy tutorial on the interpretation of chest x-rays in the context of cardiac failure. My name is Simon Woodbridge and I'll be presenting this talk, which is mainly focused on an overview of the use of chest x-rays in the acute setting to help identify and diagnose heart failure, alongside a brief look into the main principles of chest x-ray acquisition, as well as the pathophysiology of heart failure to tie everything together and provide some context into what we're seeing on these chest x-rays. So we'll move on to the learning objectives now for this talk and how we're going to approach everything. So I'll start off by discussing the very basics of chest x-ray acquisition. This will be about how the image is actually created that we see in day-to-day clinical practice and why we see what we see essentially on the end image. And then I'm going to introduce the pathophysiology of heart failure, so what actually happens. This is going to be a pretty basic overview of pathophysiology here, but I will talk in particular about how this affects the lungs, as this is obviously what we're going to be analysing on the chest x-ray. Then I'll talk a little about the role of radiology within the diagnosis and management of heart failure, and how there are various radiological modalities that can assist us with identifying and evaluating the severity and even the etiology of heart failure in a particular patient. And then I'm going to bring us on finally to the fundamentals of how to identify features of a chest x-ray that might point towards a heart failure diagnosis, and of course tie this back to the pathophysiology of heart failure. So why this topic in particular? Well, heart failure and I guess the exacerbations thereof are a very common acute medical scenario seen daily in A&E attendances and also a lot of medical emergency calls that you may get on the wards. Of course, clinical examination and history, it's paramount in any deteriorating patient. But the chest x-ray is, for obvious reasons, a very widely requested investigation when a patient is deteriorating, especially from a respiratory perspective. With, for instance, an increasing respiratory rate, decreasing oxygen saturations, etc., etc. So we can gain a quick insight into what chest pathology might be present to cause the deterioration. So I'm generalising here, but in principle, a chest x-ray should be easily attainable in a hospital setting. With portable x-ray machines that speed up the process greatly. Therefore, a solid foundation knowledge of the key radiological features of the main chest pathologies that can be picked up via a chest x-ray can allow us as clinicians to reach diagnostic conclusions more efficiently and with greater accuracy as well. Then ideally, to follow on from that, you initiate treatment faster, leads to better patient outcomes and hopefully patient stabilisation if you have your acute medical emergency, etc., etc. Of course, clinical correlation does come into it as well. So your chest x-ray findings should always be interpreted, in tandem with what you're gaining from your clinical examination of the patient. So without further ado, let's move on to the basics of chest x-ray acquisition. So chest x-rays are essentially obtained using what we'd call projectional, or in other words, plane radiography. So this basically means that the beam projection of x-ray radiation is used to produce a two-dimensional image. In practice, in very simple terms, an x-ray beam, or let's say lots of x-ray beams, are fired at a detector screen which composes the end image, and your patient is placed in between the beam source and the image detector. Now, the resultant image that's processed, it's all based on the concept of x-ray attenuation. So in essence, attenuation refers to the amount of x-ray radiation that is in some way absorbed or distorted by body tissue and hence doesn't reach the detector. Attenuation is directly proportional to density of material. So what I mean by this is bone or metal, for example, or any tissue or material with a high density is going to provide high attenuation. But air or fat that has much lower density is going to provide a low attenuation, so lower distortion and absorption of those x-rays. So the x-ray detector receives the x-ray radiation as what we'd call remnant radiation, which, if you want to put in very basic terms, is sort of what is left over from the beam source. And if you put this on a grayscale, low remnant radiation that reaches the detector passing through high density tissue is processed as white or light grey on the image, and high remnant radiation, that of a low density tissue that it passes through, is processed as dark grey or black. Now, all this comes together when we look at our first chest x-ray in the talk, as you can see on the right in this slide. So this is an erect chest x-ray taken with the patient holding a breath in inspiration. So notice how the area of the lungs in general appears black, as they contain all of that low density air on inspiration. It allows all those remnant beams to reach the detector to travel through that low density tissue, or low density air even. And the ribs will show up as a lighter grey, as we can see superimposed on the lungs almost in the image, lighter grey than the lungs, because of their higher density attenuates the x-rays more, and it allows less remnant radiation to reach the detector. So hence this is processed as the lighter part of the image, and this is how we can see those ribs overlie the lung fields in this x-ray. So if we also look at where the heart sits as well in this x-ray and the overlying ribs here, the reason that we can visualize the ribs is purely because of the difference in density between the heart tissue and bone tissue. Hence, bone is appearing slightly brighter due to its higher density than the heart, myocardial tissue underneath, and even the blood within that's pumping through the chambers. I don't have a chest x-ray here with something like a metallic valve in situ or a metal surgical plate, for example, but I'm sure most of us have seen x-rays with some kind of metallic structure on the image, which is obviously displayed as bright white. And there's a small diagram on the left of the x-ray as well that is quite generalised, but it just gives a brief illustration of the colours that we can expect in the end image related to the density of the material concerned. Next, I want to talk about the positioning of the patient when the x-ray is taken. Chest x-rays can be taken with the patient in a variety of positions depending on the clinical scenario, such as, are they an ambulatory patient walking into the radiology department for an outpatient x-ray, or are they a sedated ICU patient in bed? For the purposes of this talk, we're just going to focus on PA, or posterior anterior, and AP, or anterior posterior x-rays. In general, the gold standard, in inverted commas, chest x-ray would be a PA view, where the patient stands with their back to the x-ray source and their front against the detector, just like in the top image on the right in this slide. Because the beam source emits x-rays in this outward fashion, or more formally via divergence, structures that are closer to the beam source are going to take up more of the detector space than those further away from the beam source. You could draw perhaps a parallel with shadow puppets, for instance, where the closer you might put your shadow towards, or your puppet towards the light source, the larger your puppet's shadow is going to appear on whatever projectional surface you have, let's say the wall opposite. Hence, in a PA view, anterior tissues like the heart are going to be smaller on the image than if taken with an AP view, as the heart lies further away from the beam source in your PA projection. And as such, as the heart is less magnified in this PA view, it is generally considered a more accurate representation of heart size compared to AP views, and the PA view is generally considered to be the most ideal projection for a good quality chest x-ray, with the patient in a full inspiration breath hold while the x-ray is taken. Let's move on from x-ray physics for now and talk about the pathophysiology of heart failure in very basic terms. Heart failure is essentially defined as the inability of the heart to provide sufficient blood flow to meet the metabolic requirements of tissues or accommodate venous return to the heart. This can result, of course, in tissue underperfusion, as well as the inability to maintain an efficient flow of blood around the circulatory system. This inefficiency leads to a backlog in venous return as the heart pump function decreases, and this as such increases the hydrostatic pressure within these vessels, and over time fluid leakage from these vessels occurs into the surrounding tissue spaces, or the interstitium. Remember, I'm speaking in really broad concepts here for the purpose of this talk, but fluid accumulates in two main spaces: the lungs, which we'll focus on obviously for this talk, and the peripheral tissues. Symptoms therefore include shortness of breath, mainly on exertion, shortness of breath on lying flat, known as orthopnea, and waking up in the night with shortness of breath, which is known as paroxysmal nocturnal dyspnea, or PND for short. You can also get body swelling from pitting edema peripherally. This mainly occurs in the legs or ankles and can also occur with abdominal swelling as well, known as ascites from fluid buildup. So the shortness of breath essentially stems from pulmonary edema, which occurs as the left side of the heart fails. This leads to fluid leakage into the lungs from the venous return into the left heart, which are your pulmonary veins essentially. The peripheral swelling occurs from peripheral edema, where the same process or physiology occurs, but mainly more towards right-sided heart failure, where the systemic venous return it undergoes fluid leakage, and that causes the edema that we see in the peripheral tissues. Since we're looking into chest x-rays, they're not going to be very helpful for assessing peripheral edema, so we'll be focusing on how this resultant pulmonary edema and the lung changes that we see because of this can be identified. So, we're soon going to delve into how the chest x-ray can help us identify heart failure presentation, but I'll just outline some other main radiological modalities that all play a role in the diagnosis and evaluation of heart failure. Obviously, the chest x-rays here, it's quick to acquire the image, and we'll go on to some of the hallmarks, obviously, to identify left-sided heart failure, which it's very useful for. But what you're not going to get with a chest x-ray is a thorough evaluation of heart function or such detailed information. It's a picture taken at one snapshot in time, so you're not going to see how the heart pumps in real time or gain any measurements of important parameters like ejection fraction or valve gradients or anything that's going to provide any particular diagnostic value. CT can be useful if we think of this modality like a more detailed X-ray in this case, because this is essentially what it is behind the scenes, cross-sectional imaging using X-ray, radiation and attenuation to form a cross-sectional image. Helpful if we want to perhaps confirm what an X-ray might suggest in sliced cross-sections and improve our accuracy, but again we're probably not going to rush to CT scanning to gain any helpful measurements of heart function. It is technically possible if the images are acquired in time with a patient's ECG tracing. This is called ECG gating, but much more popular is the echocardiogram. This uses ultrasound to obtain a completely live view of the heart, and it is by far the most common imaging modality used to assess heart structure and function. Most, if not all, heart failure patients will have had an echocardiogram performed, or at least have been referred for one. Echocardiography can build upon a patient's initial heart failure diagnosis, and its role can be more to evaluate the severity and etiology of heart failure. Perhaps a patient might have a very stenosed aortic valve, or part of the ventricle wall isn't pumping as it should, aka a wall motion abnormality. The echo is really useful at picking this up and giving some clues as to why the heart failure might have occurred. Finally, cardiac MRI is also incredibly useful to assess heart failure. This is most likely less quick to obtain than an echocardiogram for your patient, but it can provide very detailed pictures of the heart and so is useful for accurate structural imaging. And it can also, among other parameters, provide very accurate measurements of ejection fraction. Now though, back to the humble chest x-ray, and I'll go through the main hallmarks of heart failure that can be visualised on a chest x-ray. This follows a simple A to E mnemonic approach, but like in almost all mnemonics in medicine, obviously, the key letter isn't actually always in the first word. So, A stands for alveolar edema, B stands for Kerley B lines, C stands for cardiomegaly, D stands for diversion of upper lobe vessels, and E stands for pleural effusions. We'll go further into each step as to why this occurs and how this is visualised. But if you don't mind, I actually want to explain these by changing the order and approach this in a kind of chronological fashion, as certain changes are mainly seen as certain milestones of severity, although this isn't an absolute rule. Also, we're assuming that pure left-sided failure in this talk for the purposes of assessing pulmonary edema only and fluid overload within the lungs. Firstly, we have diversion of upper lobe vessels. This occurs because of the failing left heart. Remember, we're assuming left-sided heart failure in all of these cases, being unable to pump through its venous return from the pulmonary veins, and as the pulmonary venous pressure increases secondary to a rise in left atrial pressure. This is one of the earliest signs of a developing pulmonary edema, and it can actually be seen on the chest x-ray as the pulmonary veins in the upper lobes begin to dilate, as we can see on the chest x-ray here, signified by the arrows on both sides. Next, we'll move on to the Kerley B lines. So, our increased pulmonary venous pressure from our heart failure has now translated further back from the pulmonary veins to the pulmonary capillaries. And this is really where the resultant increased hydrostatic pressure translates into fluid leakage. So it can now no longer stay within these vessels, and it leaks out into the lung interstitial tissue between the pulmonary vessels and the alveoli. We see the edema firstly in this region, and particularly at the distal lung tissue, where it is seen in the gaps between end pulmonary lobules. So these gaps are classified as the septa, plural for septum, and this is what we see with the Kerley B line. So the Kerley B line is a faint linear marking that is demonstrated in the X-ray on the right, and it is a manifestation of this interlobular septal thickening, to put it formally, and it is usually seen more towards the lung bases. On this chest X-ray, I've marked it out with the blue oval, which is on the right-hand side. They're definitely seen more prominently here as these whisker-like projections which extend medially from the lateral chest wall. You can also see some faint Kerley B lines on the left base as well, but these are a little harder to spot. Now, let's say the edema has progressed even further and we're further decompensating. Our fluid has now filled these septal and interstitial spaces between the blood vessel and the alveoli that surround the blood vessels for gas exchange, but the fluid is now starting to leak itself into the alveolar spaces. This is otherwise known as alveolar edema, and we would expect this to manifest as our heart failure severity increases, and we cannot push that fluid along the vessel as the venous return and venous pressure increases. So our pulmonary venous pressure is up. This pushes the fluid into the alveoli as well as the surrounding interstitium, in summary. And on the chest x-ray, we see this usually as bilateral opacities, as we can see in this chest x-ray on this slide. They typically extend out from the hilar bilaterally, and for this reason, the pattern is commonly referred to as a bat's wing appearance, due to the characteristic wing shape of this opacity. Also, just like to point out that the arrows on this X-ray are showing air bronchograms. So these are actually lung bronchi that are always there, but we can now actually visualize them on the chest X-ray because the surrounding edema has provided enough of a contrasting background to see this tube of air passing through. And just these are what the arrows are pointing at here. Pleural effusions can also form with the progression of edema, and as the fluid continues to leak into the pleural spaces. Here we can see a blunting of the costophrenic angles in this chest X-ray on both sides as fluid builds in these zones, thanks to gravity. And fluid can also be seen very subtly between one of the lung fissures, displayed by the arrow. Think of the Kerley B lines, but on a bit of a larger scale. Pleural effusions arising from heart failure are on the whole bilateral in presentation, but sometimes they can be present without visualising them on a standard PA or AP chest X-ray. You need at least 175 millilitres of pleural fluid in a PA X-ray for an effusion with a clear meniscus to be visible, and interestingly, in a lateral X-ray, you only need 75 millilitres to visualise a meniscus with an effusion. So as the heart remodels secondary to heart failure, it can enlarge or dilate as it struggles to accommodate the venous return and the pump function worsens still in a vicious cycle. This cardiomegaly, or heart enlargement, can be visualised on a chest x-ray, and it's more likely to be seen in a patient with quite established heart failure. We can't assess cardiomegaly on an AP chest x-ray, so if you remember back to our slide about acquisition, an AP x-ray misrepresents the heart size due to being closer to the beam source, so we can only assess heart size truly with a PA x-ray. We use what's called the cardiothoracic ratio to evaluate cardiomegaly, which is the ratio of the maximal horizontal cardiac diameter to the maximal horizontal thoracic diameter. The measurements are performed like so on this chest x-ray, which I've labelled A and B. If A divided by B equals greater than 0.5, then the cardiothoracic ratio is considered to be enlarged, and the heart can therefore be considered enlarged, or cardiomegaly can be considered to be present. Enlargement of any of the 4 heart chambers, remember, can result in cardiomegaly. So, in summary, even though I did address each feature in the order D, B, A, E, C, just to make things confusing, you can use the A, B, C, D, E methodology to help identify radiological features of heart failure using a chest x-ray. As a very rough rule, the more severe the presentation, the more likely it is for more of the features to be visible. Now, let's move on to a couple of example scenarios in practice. In this first example, Jim, a 75-year-old man, has attended A&E, although he could easily attend GP practice as well, because he's got fed up of some worsening shortness of breath he's experienced on exertion over the last 2 weeks. He used to manage walking up his flight of stairs at home well, but now he can't do this without getting pretty breathless at the top. He also finds himself breathless after he does the washing up after his meals. He can still complete all of his activities of daily living with a bit of difficulty, and at rest isn't breathless at all. He's got a past medical history of type 2 diabetes, ischemic heart disease, and high blood pressure, and he takes all relevant medications for these conditions. On examination, listening to his chest, he's got some mild scattered crackles as his lung bases. He has normal heart sounds. Examination of his ankles reveals some mild pitting edema, which does not extend beyond the ankles, and all observations are fairly normal. So, we've managed to get him an A&E X-ray for further look. And here is the X-ray back. So let's use the A to E approach to evaluate this chest X-ray, but in order this time. So, is there any alveolar edema? Well, I'm looking at both of the hyla here in the chest X-ray and assessing outwards on both sides. I'd argue that I can't really see any overt opacities here to suggest edema, but I'm pretty sure I can see an air bronchogram which I've arrowed. This might suggest some low-grade alveolar edema here. Now, looking towards the bases, I can just about make out some very, very faint Kerley B lines, more so on the right side, which I've circled, suggesting an element of interstitial edema here. Handily, I've also performed the cardiothoracic ratio. Visually, dividing A over B probably gives a ratio of just over 0.5, so we could consider the heart to be slightly enlarged here. What is clear though is the upper lobe diversion, marked by the 2 top arrows I've drawn. We can clearly see these are dilated pulmonary veins showing up with enough clarity on the X-ray, and that suggests an increased pulmonary venous pressure from left heart failure. I also think there's an element of a pleural effusion perhaps, certainly some further interstitial involvement, as there looks to be a faint line of fluid which is lining the horizontal fissure on the right, which I've circled in the uppermost circle here. So, resultantly, this patient was newly diagnosed with heart failure. Given his relatively mild symptoms, he was commenced on oral diuretics and referred for an outpatient echocardiogram with cardiology follow-up. Now, unfortunately, it's 2 months later, and Jim was admitted to your hospital this time, as his breathlessness worsened to having shortness of breath at rest, and he was finding he was unable to cope at home with his breathlessness. You find that his compliance was low with the oral diuretics that were prescribed, and his symptoms resultantly progressed. No worries though, as he had an excellent response to IV diuretics on the ward, and he was at that point awaiting discharge home pending a package of care review. His past medical history remains the same, though he now has a diagnosis of NYHA Class 2 heart failure to add to that, which is symptoms on exertion. You've now been called to see Jim as a medical emergency, as he'd recently complained of severe central chest pain to his nurse, And when you see him, he is clammy and he's very, very breathless. So you perform his observations. He's got a respiratory rate of 35. He's got a normal temperature. He's got a low blood pressure with tachycardia. And he's got saturations on 89% after they whacked his oxygen up to 15 litres. He was on room air before. On examination, you can hear diffuse crackles bilaterally in all zones with normal heart sounds. He has pitting edema to his mid-shins this time, and crucially his ECG that's just been taken shows new ST elevation in the inferior leads. Luckily, you've requested a portable chest x-ray which has quickly been taken for you to assess. And conveniently, here is the x-ray. Okay, so for the purposes of the talk, this isn't actually an x-ray from the same patient, but what are we seeing this time? Starting again with A, we can see clear alveolar edema here. I've tried to draw this, and it is actually projecting out in a kind of bat swing pattern across the upper, mid and lower zones of the chest x-ray. We've definitely got some clear air bronchograms here, which I've arrowed, which I'd expect to be present with this level of edema. The two ovals at the bases are showing some pretty clear Kerley B lines. They're extending centrally like whiskers, almost from the basal ribs. I think assessing cardiomegaly is difficult here because that alveolar edema has really kind of distorted that cardiac border, and I think it makes it quite difficult to perform a measurement in this case. Again, the edema is quite prominent, that it's harder than the first image in my opinion to locate upper lobe vessel dilation. But I think I've managed to locate them, which I've shown by the two uppermost arrows here. We can't see much evidence of costophrenic blunting to suggest pleural effusions on this x-ray, but if we look at the right lung, there is a clear whiter line which runs along that horizontal fissure, which suggests a level of fluid along this fissure, I would say. So, in conclusion, we're dealing here with a case of acute decompensated heart failure with clear alveolar involvement and pulmonary and interstitial edema. Most likely in this case, given the ECG findings and the crushing chest pain secondary to a STEMI, which is causing cardiogenic shock. So, after these examples, I'll now draw this talk to a brief conclusion. The main takeaway points from this tutorial are: the A2E approach sets a useful foundation for interpretation of chest x-rays in the context of heart failure pathology. While the process might not happen in the order of A2E, it is an easy-to-learn reminder of the main hallmarks of what may appear on a chest x-ray in a patient presenting with symptoms of heart failure. Also, the chest x-ray is a useful tool for aiding with the identification of heart failure, especially in the acute setting, due to its relatively rapid acquisition compared to other imaging investigations. This goes back to the point I made closer to the start of the talk, where, because the chest x-ray can only provide limited information at a single point in time, it is best used to aid diagnosis, but you'd have to team this, of course, with clinical history and examination. Also, there are other powerful imaging modalities available, which are best suited for further evaluation of the structural and functional abnormalities which might contribute to a patient's heart failure. Further information such as severity and the etiology of a particular patient's heart failure can also be obtained. And I would say echocardiography is definitely the most common investigation utilised for this purpose. So that concludes my talk on the interpretation of cardiac failure using the chest x-ray, and thank you very much for listening.